Good afternoon, everyone. My name is Chris Klinger, and it is my pleasure to welcome you to the 2021 edition of the World Hospice and Palliative Care Day special lecture. I'm welcoming you on behalf of our host organizations, the National Initiative for the Care of the Elderly, Pallium Canada, and the Institute for Life Course and Aging at the University of Toronto. As many of you know, World Hospice and Palliative Care Day is an international day of action geared to foster the global hospice and palliative care movements. It's the time of the year where we also like to honor all the work that is done in hospice and palliative care, with the theme this year being Leave No One Behind, Equity and Access to Palliative Care. I would also like to take this opportunity to acknowledge the land from which I am talking from. I'm talking today from the city of Toronto that is situated on the territory of many nations, including the Mississaugas of the Credit, and is also home to a diverse set of First Nations, Inuit, and Métis people. I'm very grateful to have the opportunity to be on this land, and I believe that the work that we're collectively doing in hospice and palliative care contributes to the healing journey that we're all on together. In terms of the program for today, you will see that over the next 75 minutes, we will have an opportunity to learn about the Palliative Care Echo project from Jeff Moat, who is the CEO of Pallium Canada. We will then have the special lecture with Professor Irene Higginson from the Cicely Saunders Institute and King's College in London, UK. And after that, we will have an opportunity for questions and answers. The award this year will be given by Dr. Esme Fuller-Thompson, the director of the Institute for Life Course and Aging over at the University of Toronto. In terms of some of the housekeeping items, please have an opportunity to introduce yourself through the chat, give us an opportunity to know where you're coming from, and then with the Q&A section that is over here in the bottom of the page, that's an opportunity for you to ask a lot of questions that we will try to get to at the end of the lecture. The session here will be recorded, and we'll have an opportunity for you and everybody else who is interested to actually download it from eHospice Canada. So thank you very much again for joining us today on behalf of the host organizations, the National Initiative for the Care of the Elderly, Pallium Canada, and the Institute for Life Course and Aging. And I turn it over to you, Jeff, now for the update on Pallium.
Wonderful. Thank you so much, Chris. And thank you all for attending today's World Hospice and Palliative Care Day special lecture. My name is Jeffery Moat. As Chris mentioned, I'm the Chief Executive Officer of Pallium Canada, which is a national nonprofit organization dedicated to building professional and community capacity to help improve the quality and the accessibility of palliative care in this country. Before I turn the floor over to our guest speaker, I would like to take a moment to put this special lecture into context vis-a-vis a new national initiative called the Palliative Care Echo Project. Next slide, please. Before I speak about this initiative, I want to provide some background on Project Echo, which is the model or the foundation off of which the Palliative Care Echo Project has been built. Project Echo, and Echo stands for the Extension of Community Health Outcomes, began back in 2003 at the University of New Mexico by Dr. Sanjeev Arora, who was a liver disease specialist, who recognized the challenge of serving hepatitis C patients in the rural and remote parts of the state, who in many cases had to travel many hours into Albuquerque to see a specialist. And Dr. Arora's vision was to leverage technology to support primary care providers in these communities with the knowledge and the skills to provide care to their patients. And he did so by creating virtual communities of practice and connected specialist teams at a hub to healthcare providers in these communities. This model served and continues to serve to move knowledge and information rather than people. And from this early work, really a movement has begun. Project Echo has been rolled out into over 40 countries now. There's some 860 Echo networks operating, and they've engaged so far 140,000 healthcare professionals. Next slide, please. Pallium Canada is very pleased to be leading one of the first national ECHO projects called the Palliative Care ECHO Project. And this is a 5-year initiative. It's funded by a financial contribution from Health Canada, and it's been created to cultivate communities of practice, or what I like to call virtual learning networks, among healthcare providers who care for patients with life-limiting illness and their families. Project ECHO has been described as a performance optimizer, a high-speed internet connection to healthcare systems that spreads, in this project's case, palliative care information across healthcare systems from subject matter expert teams to the front lines of care. The Palliative Care ECHO project isn't designed to replace core fundamental training on the palliative care approach through courses such as LEAP, Learning Essential Approach to Palliative Care. And while courses such as LEAP are not a prerequisite to participate in the Palliative Care ECHO project, we do encourage ECHO participants to complete LEAP training to have that foundational knowledge so that they can make the most out of their participation in these ECHO webinar sessions. Next slide, please. The entire strength of the ECHO model lies in its connectivity. By leveraging commonly used Zoom technology, such as what we're on, it enables busy professionals to share learning and best practice across rural and hard-to-reach areas, all without the need to travel, which is a great benefit in a country as large as Canada. It also serves to expand healthcare providers' networks and connections and reduces isolation. A hub represents a network of healthcare professionals. And by establishing a network of hub partners, we establish a connection, in some cases, with thousands of healthcare providers who, on our own, we would have a challenging time reaching. A hub partner hosts ECHO sessions, again, which are delivered through Zoom technology, for the healthcare providers that they represent. And we work with each of the hub partners to identify and prioritize their network's palliative care education needs and information needs, and we help curate content, and communities of practice are established and activated through Zoom. The Hub Partners Network becomes connected to subject matter experts, knowledge information is shared, and a rich dialogue ensues. Information is shared multi-directionally, back and forth between subject matter experts and healthcare providers, and among healthcare providers. All participants learn from each other as new best practices emerge, which in turn helps to reduce disparity. A hub can be defined geographically by a setting of care, by a profession, a specialty area, or the population they serve. It's typically represented by an organization. And as you can see on this slide, we have onboarded 6 hub partners since the beginning of the year, with more on the way. It's also a model that supports the rapid dissemination of information as required. In a similar way to how many of us responded to the information needs of frontline healthcare providers during the pandemic. And as the linchpin at the center of this hub and spoke model, Pallium is better able to understand the learning and the professional development needs of our partners and really help minimize the duplication and replication of effort by connecting our partners to existing content. Before I go to the next slide, Holly, is there everything all good?
Yep, we're just having a delay with Irene coming, but I think she'll be joining us soon.
Wonderful.
Yep.
Okay, thank you for that. Okay, you may be asking, what are these ECHO programs? There's 2 types of ECHO programs. There are ECHO programs hosted by our hub partners and delivered to their healthcare providers that they represent, and examples of which you can see in this table. And there are national ECHO programs and webinars that Pallium curates for the benefit of all hub partners and their healthcare providers. And as you can see, as part of its national ECHO programming, Pallium has established communities of practice for personal support workers, healthcare providers working in long-term care, cardiology, just to name a few. And in fact, this World Hospice Palliative Care Day special lecture is another example of a national ECHO standalone session on priority topics. So if you're interested in finding out more about the Palliative Care ECHO project, please visit the URL that you see on the screen there at the bottom, echopalliative.com, www.echopalliative.com. Equity in palliative care is an incredibly important topic. So we're thrilled to have Professor Irene Higginson joining us today, who I'd now like to introduce. It's really a pleasure for us to be able to introduce Professor Higginson, who's the Professor of Palliative Care and Policy and Vice Dean of Research of the Florence Nightingale Faculty of Nursing, Midwifery, and Palliative Care, and Director of the Cicely Saunders Institute at King's College London. Under Professor Higginson's direction, the Cicely Saunders Institute, as the world's first purpose-built institute of palliative care, has brought together teams from diverse areas of palliative care in a collaborative, multi-professional environment for clinical services, research, and education. Professor Higginson also holds roles as Director of Applied Health Research at King's College Hospital NHS Foundation Trust, Scientific Director of Cicely Saunders International, and is an NIHR Senior Investigator with extensive experience in leading and delivering national and international multidisciplinary collaboration in palliative care. She's led the development and implementation of the Masters of Science Diploma and Certificate in Palliative Care at King's College London, supervises several PhD students, and is active in teaching. The Web of Science has recognized her as a highly cited researcher. The award recognizes the world's most influential researchers who have produced multiple papers, ranking in the top 1% in their field by citations. She's also appointed an officer of the Most Excellent Order of the British Empire. It gives me great pleasure to turn the floor now over to Dr. Higginson. Welcome.
It's such a pleasure to be here. I love connecting with my my colleagues in Canada. You do such amazing, wonderful work. So it's a pleasure to be here. Okay, I love the title of your session today. Leave no one behind. I think that's a wonderful title. And so what I'm going to talk about is the idea of equitable access in palliative care for the 21st century. And thank you very much for inviting me here for this lecture. I wish I could be with you in person. And I guess I'm going to cover these areas. So first of all, what do we know about the population health and social care changes? What do we know about the facts of palliative care? And what can it offer? What do we think about equity of access to palliative care? And in it, I'd like to reflect a little bit on a symptom that is of particular interest to me, on breathlessness. And I would like to share with you some very recent work that we've been doing with the charity Cicely Saunders International on a 7-point action plan for better palliative care. And at the heart of everything is our thoughts about what Cicely told us right at the beginning. You matter because you're you matter all the days of your life. Now, this slide will be familiar to all of you, but it's one that I admire, and the model of bow ties by Pippa Hawley. If you're on the line, Pippa, well done with this. I think that this is a great model. It fits with what Cicely said, and it's about the idea of palliative care adding quality to life, putting the person before the disease. And Cicely captured this also in the idea of body and mind, the science plus caring, in research, in education, in care. Now, we know that the need for palliative care is going to increase really quite dramatically. And that is of concern to us. In particular, what we are concerned about here is that by broad age group, the population is projected to increase by 2021. And importantly, life expectancy at birth is going to increase. And you can see the data there, fourth down from the top is Canada. If we think about where we are now in 2020, then what you can see is this huge growth in the numbers of people, particularly in the older age groups. Now, of course, this may change with shifts in population. These predictions were done before the pandemic really has been taken into account. But if we go back to palliative care needs and we try and measure these as the Lancet Commission on Palliative and End-of-Life Care did as serious health-related suffering, then these needs are projected to escalate. And again, we can see that the increase in the number of deaths, particularly in the lower middle income countries, and to some extent the upper middle income countries, is going to be very large. And although Canada is not one of the areas of the world that's going to grow most fast, it's nevertheless still going to grow a lot, 57% increase, as opposed to 155% increase, which is what you'd see in the low income regions. So even a 57% increase is extremely large increase in the number of people who will have serious health-related suffering over the period of time to 2060. We also know that around 20% of healthcare resources are spent in the last year of life. There's some excellent work that came out quite a number of years ago from Winnipeg showing this ever so clearly. We also know that most deaths are from chronic or progressive conditions. We know that end-of-life care is central to any national health services responsibility. We know that in the UK, we're going to have a 42% increase in people needing palliative care by 2040. And yet, we also know that care quality at the end of life is often not optimal, budgets are constrained, and we also know that palliative care improves quality without increasing costs to the NHS or society and possibly saves money. And we can see how the projected deaths from in the past to what is projected for the future shows how we're going to see mostly an increase in the older age groups. We also know that if we model how many people will die and where they'll be cared for, this shows the data that I've shown you on the left-hand side, the 42% increase in the need for palliative care and the increase in the number of deaths. But if we look at where people might die and we try to map forward the trends, and this is very, very tricky to do because it's very much guessing, then we need to think about where we're going to have resources. The current trend in the UK has been towards a reduction in hospital deaths and an increase in home and care home deaths. But if this continues, then where are we going to find the capacity in the community for all these people to give a high quality end to life? And I think we also need to think about the future of medicine and the 5 Ps. It's going to be predictive medicine, preventive medicine, point of care medicine, paramedic medicine, so paramedic healthcare, so referring back to people's own baseline, and personalized care, individualized treatment to everybody's own standard. There'll be possibly life on Moon or Mars, fusion energy and renewables, but we're also going to have much more patient empowerment, technology, robots, etc., and the wearables, which has implications and potentially opportunities for palliative care. And we also need to think of the future of health and social care and the difficult paradox of both increased specialization across medicine, nursing, and allied health professionals, and yet also the challenge of multimorbidity. So how come and how do you balance the fact that we have more people specializing, for example, in heart disease and heart failure and care, and yet we have a multimorbid population that has some heart failure, but also some lung failure, some dementia, etc. That leads to healthcare safety challenges. What is the workforce for direct care? Questions, as I said, about robotics, AI, computerized therapies, the different professions, how we manage empowerment. And palliative care is important in getting this right. You all know this, but it's important in getting this right. And it is important across multiple settings. So inpatient palliative care units, hospital palliative care teams, freestanding hospices, home palliative care, and also importantly, I think, home nursing. Now, there is consistent evidence that in favor of palliative care, providing that in terms of improving quality of life and symptoms for people. It means that we have evidence that palliative care improves symptoms, improves quality of life, and helps people to be cared for where they wish. And here's just some data recently published last year from the new updated Cochrane review on hospital teams, looking at health-related quality of life. the also effect of early palliative care in cancer, another Cochrane review from a few years earlier, again, showing improvement across a range of outcomes. Does palliative care affect whether more people would die at home? Yes, it does. Barbara Gomez is updating the Cochrane review and including only randomized trials now, not controlled clinical trials, but only the randomized trials. But still, I think the data will show an improved odds ratio of home death compared with conventional care for people who get palliative care. And do we know the effect of palliative care on health and social care costs? This evidence is more tricky, but there's some data here in cancer from Peter May and colleagues working across the US and Ireland. And what you see here is that the longer you have in palliative care in a hospital team, the greater the cost savings. So the longer you have in palliative care, and they did this in a slightly odd way. They looked at time from consultation after hospital admission. So if somebody had been in hospital a very long time, the cost saving was not great. But if they were referred quickly to palliative care, the cost saving was much greater. And they also reflected on the issue of multimorbidities. Now, those are important. They're higher in people who are deprived. You can see here the higher levels across multiple diseases of multimorbidities, so other morbidities in the most deprived areas. There was a recent report from the UK Academy of Medical Sciences into this about looking at how healthcare systems can be better organized to do this. And they particularly flagged that there may be opportunities to take guidance from fields such as palliative care, almost arguing that our field in particular had a role here. And interestingly, we now know that the cost savings of palliative care are greater when people have multimorbidity. Here is the work by Peter May and Charles Normand again, showing that a 22% cost saving when people have comorbidity scores of 2 and 3, but a 32% cost saving when they have higher multimorbidity scores of 4 or more. And the team followed this up with a meta-analysis here showing quite largely that if people had more multimorbidities, you saw considerably more cost savings. So exciting and important potential data. So what next, and what do we need to think of? And I think here we need to be thinking that palliative care expertise is fully available in all settings. And we need to be thinking about 24-hour care, competent evidence-based care, better integration and coordination with treatments, therapies, and care improved through research. And I just want to pause a little bit now and reflect and dive a little bit more deeply into some of that equality data before I come to some thoughts and ideas about the way forward. So I think that one of the challenges that we've had in a number of countries is that the strategies that have been introduced, and this is UK data with the end-of-life care strategy, the strategies that have been introduced have not necessarily impacted enough those individuals who have either multimorbidities or deprived from deprived areas. So let me give you a couple of specific examples of this. So this is some data showing that for whether people died in hospital or not, you can see a slightly rising trend in hospital deaths, and it's pretty high anyway, 65 to 70%, increasing. The end-of-life care strategy is introduced. You begin to see a bit of a dip. It's continued. It continues to fall. And that's whether you adjust it by age and gender or not, for 2 key diseases, chronic obstructive pulmonary disease and interstitial pulmonary disease. But if we look at the trends over time, for people who have comorbidities, this is the same period over time, the same data, but here the sample is broken out by people who've got 4 or more comorbidities, 3, 2, 1, or none. And you'll remember from this graph, if I just hop back to here, you can see that around 2004-5, we begin to see it coming down, and it's not a big change, but there's a little bit of reduction after 2008. But let's go on. Here, 2004, we begin to see the shift. But what happens for both COPD and interstitial pulmonary disease, that it is the group of people without comorbidities who are not coming back into the hospital. And the more comorbidities you have, the less likely you are to have been affected by this, such that those with 4 or more, or in an interstitial pulmonary disease, almost 2 or more, possibly even 1 or more, weren't really affected by these improvements. And I think that that's an important challenge to these strategies that are introduced. If we look at whether inpatient hospice death is affected by social factors, so here, if we look at least or most deprived areas, then what you can see in England during the period of the introduction of the end-of-life care strategy is a widening of the social gradient between care, and you also see some data on whether ethnicity affects things, although in that data there isn't such a clear time trend. And if we look at whether people with dementia are affected at the end of life, what we can see interestingly in this is that towards the end of life, there are important neglected populations where in the last 3 months of life, those individuals who had transitions early on have them hugely later. Those individuals who didn't have early transitions actually don't increase so much. So there's something interesting going on about the group of people who change in this way. And this has led me to increasingly think of a hypothesis that I'm working on at the moment of catalytic interactions. And my hypothesis here is that there are 2 strands of inequities in palliative care that exist. There are those inequities that pervade across health and social care and society, which exist also in palliative and end-of-life care. And then, in addition, there are specific inequalities that are specific to palliative and end-of-life care due to its nature. And these seemingly small things, when added together, become, for those of you who like the chemistry, reciprocal catalysts. It's a bit like what we say about teamwork. The whole is greater than the sum of the parts, but more than that, because I think that these 2 strands of inequalities actually accelerate the systematic and systemic injustices. So it becomes a snowball. Something you're very familiar with in Canada, I'm sure, is snowballs, and the snowball gets bigger and bigger until there really is no point going back. Now, in some ways, my interest in inequalities in palliative and end-of-life care began in a way with some very simple data, and began with the first area of the hypothesis. Could we see that inequalities that existed generally in healthcare are also applied to palliative care? So deprivation is a great example of this. There is an index of deprivation. There are a number. This one is called the Townsend, and you could see that the standardized mortality ratio, SMR, was higher in the more deprived areas. And I thought, well, I wonder if there's any relationship between where people die. And lo and behold, there was. So we find that when we looked at these 44 electoral wards, so these different areas in London, the proportion of home deaths over 5 years was inversely related to whether people died at home. So in one ward, which was quite an affluent ward, the home deaths were particularly high, and in a number of other wards which were more deprived, the home deaths were lower. If you think about where these areas were, you may be familiar with central London. Actually, I was working in this part of central London, a rather interesting area to work in, near Westminster, St James's Park, Hyde Park. And interestingly, my affluent wards included Buckingham Palace and the Boulevard of Billionaires. And my deprived wards in the north of the borough included some of the poorest areas of the UK. And this idea of these aspects pervading continues to this day. And I'm going to give you a couple of examples. The disparity that we found in the UK was echoed by Costini and colleagues, who found exactly the same data using unemployment this time instead of the deprivation index, because they didn't have deprivation index, but you see the same pattern. Now, if we move to 2020 and we look at COVID, and this is UK data, I apologize, I don't have Canadian data, and I hope that your data is better than this. Because the terrible thing that you can see in this data is that as you move from the least to the more deprived areas, you can see that the all-cause death rate, which is shown in the grey, is higher, and the differential impact of COVID deaths is also much, much higher. So in deprived areas, all deaths are higher, and the deaths due to COVID were even higher. And if I come to looking at ethnicity with COVID, and again, this is quite shocking data in a way, in this really elegant study published, I think earlier this year, what we can see is that the age-adjusted odds ratio of COVID-19, this is data for men, but the data for women is similar. And you can see across different groups, the element that is explained in the red by living in a household, which is multi-generational, which had a small increased effect, but not huge. The element that was explained by geography, household characteristics, socioeconomic factors, and prior health status, and that's the green area, which is also larger. And then the residual component that was unexplained by either of these two aspects in the model and seems to be an additional factor which is affecting these communities. And if we come back into palliative care, and we did a multinational survey of services, and then we analyzed the data and the things that staff and services told us. And what we saw was quite interesting in these data. It was just published earlier this year, led by my colleague Sabrina Bajwa. You can see that although people might think that they're making an equal response, there are blocks to an equitable response by various components of how we deliver palliative care. And that research included a number of key recommendations that should be put into place, including flexible policies, including changes and thinking about how assessments are integrated into care. The next, though, part of my hypothesis is the palliative care specific inequalities. And I think all through palliative care, we've been aware of these, but I'm not sure we've articulated them quite this clearly as I am at the moment. The the John Hinton put forward the idea that the dissatisfied dead cannot noise abroad the negligence they've experienced. And he published this and so on. Palliative patients are not often, they are increasingly so, but are often not a huge group who are vocal in the way that some people are when they're campaigning for particular treatments. And there is also a challenging element with the growth in patient and consumer organizations. So I'm a huge advocate of patient and public involvement. At the Cicely Saunders Institute, we have a patient and public online forum, and it's incredibly valuable for us. And it's funded largely from a combination of our grants and other aspects. But we do know that there's a number of consumer groups that are funded by various either pharmaceutical or medical device industries. And obviously these are areas that are not normally so easy for us to access, and they do change the landscape in terms of raising awareness in the field. So it's important for us to be mindful about that and to try and get the voice of patients and families into palliative care. And I know that that's something here in Canada that you've done incredibly well. The next thing is the stigma. And the stigma, it operates on multiple levels, but I mean, it's particularly important, and we see it every day as a barrier to referral, but it's also a barrier to building the field. And there are negative stereotypes. And sadly, this is a fairly recent data published in Palliative and Supportive Care by colleagues, which show that some people assign negative stereotypes to patients who choose palliative care. And these words shock me: lazy or quitter, and more positive stereotypes to others. And the whole idea of the battle language that relates to healthcare across multiple diseases, not just cancer, is a major, major challenge. And then there's the sort of abyss problem. So we know, and it's good news, that there's more specialist palliative care and hospice services than ever before. And yet it's still insufficient to provide either the expert care that people need or the support and training for generalists who normally get quite limited training in their career. And the growth has not kept up with the escalating lead that I showed you in the first slide. And generalist palliative care training skills and the ability to remain up to date is patchy. If you look across the globe, even essential medicines for palliative care are lacking in many parts of the world. And we lack basic data often on how many people receive palliative care, the problems they have, the effects of it. And there's a lack of research investment in new knowledge and better treatments, which is what we need in our field to go forward. So this abyss in access to care, data, knowledge, and capacity building creates major challenges for us. And just to flag that, in the COVID era, we did in our CovPal study a survey of the services. And although many services were caring for people with needs for palliative care, and several of our patient studies are out, and we found these different groups seen by the services. So those with underlying morbidities, those known to palliative care, those previously healthy. When you look at the data, we found that there were financial concerns. Some staff were taking pay cuts. They were concerned for service viability, particularly those in the charitable sector. And there were shortages of staff, protective equipment, and so on. And the whole premise of palliative care was often overlooked in the national response. So if you look here at personal protective equipment shortages and the difference between palliative care services that were managed in the charitable sector in the blue or the public sector in the orange, then what you can see is that in the charitable sector, they really struggled to get protective equipment. They were calling out to vets. People were trying to sew them, all sorts of things. There were also staff shortages. Medicine shortages were more hit slightly in the public sector, I think because a large number of hospital palliative care services found that all their drugs were being used on intensive care, as were their syringe drivers. There were shortages by setting. So, for example, although staff shortages were pervaded across all settings, some settings had more shortages than others. And if we look at my last problem, in a way, the access to palliative care is haphazard and is based on a referral, usually by a clinician. The evidence is straightforward. Receiving palliative care is better in terms of person-centered outcomes and the economics of the society than not, and early access is better than late. And yet the systems of entry into palliative care rely on the referring clinician identifying that that person needs palliative care. And because of this, people miss out on the best in palliative care, particularly for diseases other than cancer. And some kind of routine system of identification and referral would help this. And it could be something like the Integrated Palliative Care Outcome Scale. It could be the Edmonton Symptom Assessment System, or it could be some other holistic assessment. But look at this. This is a study that we published just recently on the emergency department attendance with people with deteriorating health. And why did they come into hospital and what happened to them? We do have this problem of people landing up in hospital with problems, deteriorating health and symptoms. And they can't get, this is UK data, appointments. So apologies to those of you who have managed to do this, but here's somebody saying, you know, it's like trying to make an appointment with the Pope. Or people described how in hospital their recovery was hindered because of the food and sleep problems that they had, and they felt that these were important and so on. And this is at a time, 7 years after the World Health Assembly resolution on palliative care said it was essential. So here we are, 7 years on, and we really are seeing these problems across many sectors and conditions. And my view is that we do need to get back into better referral systems and triggers using things like, I've shown an example of the palliative care outcome scale here, but using things like this, and perhaps even thinking about introducing these sorts of triggers into robot assisted or wearables or so on. And that takes me into my area of where breathlessness, and this is the last section of my talk, may be helpful to us. Breathlessness is an interesting symptom because it's very common in respiratory diseases, where people often go through a fluctuating course. And this is some hypothetical work where we were thinking of models of integrated working for palliative care for people with chronic obstructive pulmonary disease, where they don't often get the opportunity to go into palliative care. And we were looking at the idea of when you might have indications for palliative care, for example, a dip in symptoms, and therefore some kind of model of integrated working. And part of this thinking built on a randomized controlled trial that we'd done, looking at a breathlessness triggered support service, which had early palliative care integrated with respiratory, so working with respiratory services. And what we found is a 16% improvement in quality of life, those that got the breathlessness support service versus the control group. And we also found, interestingly, a survival advantage for those that got the breathlessness support service and no difference to healthcare costs. So what does this really mean? And is there anything else to support it? So yes, there is. So there was a meta-analysis then published just a couple of years ago, looking at the data from 18 different sorts of services and randomized trials. And by and large, we see a benefit in terms of the effect of breathlessness on the person and their overall either psychological well-being or quality of life. And so despite these services all being a little bit different, there is something about the idea of the holistic approach that is important. And when we teased out the study to look at the key elements of these services, then what you see, and here's the links, you can get all of this information from the web. You can see the sort of pack that we gave people for self-help, the plans. We had an initial palliative care and respiratory assessment, and then a home physio assessment, and then a final palliative care discharge. It was brief. We're currently working on turning it into turning the first element of some of these aspects on paper here into a self-guided intervention that people can do themselves called Self-Breathe. And we are reflecting hard on what enables people to be at home. And this is some data that I'm particularly proud of a meta-ethnography that shows that for people to be at home, they need the presence of services, which is 24/7 availability and home visiting, and they need competent services. So they have services that can control their symptoms and tell them about them and manage the quite complex medicines, actually, when you're dealing with opioids, etc., well, and also can communicate well. And these two things, presence and competence, give a feeling of security with the trusted team, which then allows for both living of life at home and preparation for death. So this can be done, and these are the key sorts of ingredients. And if you're interested, some of the work that we've done on the breathlessness support service and the breathlessness work, we've developed into an e-learning platform, which you can find here. You can find the link there, and then you choose the breathlessness from the courses and can take that. And an action plan, I think, is what we need to start to join up the response in palliative care across the sector. And so partly in response to the COVID and other things, at the beginning of 2021, the charity Cicely Saunders International published You Matter Because You're You, an action plan for better palliative care. The link is shown there. And it has 7 simple points. First of all, about ensuring that palliative care is provided where people are cared for. Secondly, and there are more detailed recommendations on each of these, making joined up care a reality. And thirdly, empowering patients to have greater choice and control of them, including when to be referred to palliative care and how to be referred, so that you're not just sitting in and waiting for a clinician to say that you're being referred. We empower patients to come forward when they have symptoms of cancer, when they have symptoms of heart failure. We encourage them to come forward, get tested, get checked, make plans. But we don't encourage people to come forward in palliative care where symptom management and other things may help them. Then investing in community services so people can remain at home, but these are the sorts of services that meet our criteria for ensuring security, so presence and competence. Ensuring that all healthcare professionals and social care professionals, I would say, are get good training and keep up to date. I think we need a system of outcome measures for improvement and learning. And I know in Canada, you've actually made great strides with that, which is fantastic, working with people like Deb Dudgeons and so on. And then we need research, because we do need to get better at many of the treatments that we're actually not very good at yet. And what I hope is that actually, if we recognize this, palliative care methods and approaches are a solution for much of health and social care, because health and social care, as I said at the beginning, is trying to respond to a multi-morbid population and challenges. And if I think of my snowball, as I showed you earlier, then what I hope is that with this approach, we'll actually tackle these dual inequities that are existing in palliative care. So I'll just really end with some take-home messages. In my view, palliative care is central to the future of healthcare and is growing in need. It understands multi-morbid populations, and so therefore it should be central to what healthcare systems do in the future. It suffers from inequities just as other healthcare systems do, but it also has its own specific inequities in palliative care. There is evidence that it works, so it's key to ensure that it's available. You can improve the triggers, perhaps with symptom triggers, such as to holistic breathlessness support services, which could be a simple symptom deterioration trigger that takes you into this type of service and then might triage you into continued palliative care or short-term assessment if things improve. I've shared with you a 7-point action plan. I'm interested to know your reactions to that plan and whether it would be useful for you. And I think there's an opportunity to build research, capacity, and knowledge, because we have a science that puts the person before their disease. And for me, that's important for the future of healthcare. So thank you very much for your attention and your time, and also for inviting me. And I look forward to a little bit of time, I hope, for discussion.
Thank you so much, Dr. Higginson. That was fascinating and eagerly anticipated, and you delivered. We all are so concerned with equity-related issues, and you highlighted a variety of them: geographic, economic, racial inequities. This is now the question and answer section. So you'll see we've had 100 people join us, which is wonderful. I'd like to just sort of point you down to the Q&A section at the bottom of your Zoom screen. Please put in your questions. I'm going to just share the first one, which is kind of a two-part question, and ask Dr. Higginson for her thoughts on it. Is there research or knowledge about resistance from people who don't want to be referred to palliative care earlier in spite of cost savings?
Thank you. That's a brilliant question. Would you mind if I just turn the light on here in England? Because while I've been talking, the sun has been setting because it's getting dark here, and you've probably seen it going later. So I'm just going to turn the light on, if I may. Apologies for me stepping away. And I have a spare extra light there. Because now we're on the Q&A, you probably do want to see me. That's probably a bit better, isn't it?
Add some light on all kinds of things, right?
So, okay, so it's a wonderful question. So the thing that, there certainly is that situation. So let me just get to that question. I saw it there. Yeah, there we are. Is there research or knowledge about resistance? So there certainly is research and knowledge problems about that. I would say that there is a proportion of the population that doesn't want to be referred to palliative care. Some of that is about their own perceptions about it. Some of it is also where it's available. So I've seen many people change their minds or have misconceptions. There is a misconception that palliative care is all about dying. Some people even think palliative care is about euthanasia still. Even intelligent and well-informed people. And this whole business that palliative care has kind of got itself very close with end of life, which it needs to be, because end of life is part of palliative care, but it's also about living. I think the nicest anecdote I can give you was a European conference that I was at, not a palliative care one, but another one. And I was sharing a stage with a patient advocate in the cancer area and a couple of other people. And what we did, and the patient advocate said, well, I don't really want to be referred to palliative care, and you should change the name to supportive care. And my colleague, who was from Italy, said, well, what I say to people is that modern palliative care is about improving quality of life and helping people live well. And the patient rep said, oh, well, I'll have that then. You don't need to change the name. And I think some of it is that we don't explain properly what we do. And partly we don't explain what we do because we don't have the capacity building, we don't have the communication angles, we don't have the patient and public involvement groups that we should have, who can be advocates for what we have. And we don't have the research evidence showing how good we are, but we do have good research evidence, you know. And when that evidence comes forward, people do change their mind, and they may want it in different settings. So they might well want somebody coming in, helping them from palliative care at home, but they may choose not to go into an inpatient hospice because they don't want to be in an inpatient hospice. They want to be in control of things at home and have a chaos. So I think that's important, and so on. And I think it's about the data, it's about the story, and it's about the advocacy from patient and family groups of really understanding what it is. So I hope that's helpful.
Great. So her second part was, okay, now assuming we're explaining it better and people know what it is, there's overcoming the stigma related issues. So maybe you can speak a little bit more about stigma and how to address stigma.
Oh gosh. Well, if I knew the answer to that, I would have done it long ago. And I'm not sure I do know the answer to it. The first step, I think, is to keep highlighting it. I mean, you know, in healthcare and media, there is, let us say, the opposite of stigma. There is an excitement about areas of care. Breakthrough. If you read the papers, it's breakthrough, it's this, it's that. And in a way, societies and newspapers and journalists expect that. So it's how we change in palliative care to say, actually, we've had a breakthrough in how you manage this symptom, and it's going to affect so many people. We've had a breakthrough in how you talk with people, and we found that if you do this in a simple way, then you can improve things. We've had a breakthrough in how you might assess something or measure something, but it's not quite the same as discovering the new gene, even though we all know really that discovering the new gene is actually many years down the road and is only one small step in the gene journey. So maybe we're also not quite so good at communicating what we've achieved. I hope that helps.
Absolutely. So some of it is back on us to be better communicators and get out of the ivory tower and get the word out, sort of thing. Okay, Carolyn has a comment that she's interested in the managing breathlessness. Are the resources you shared geared towards patient, client, or towards practitioners?
So there's a combination of both in there. One of the things that we did in the service, which I think was very interesting and worked very well, is that we gave patients these packs. So you can take the packs and give them to patients. The new resources that we're developing with Self-Breathe will be an online or app-based program, which will be directly for patients to self-manage. And the toolkit is primarily for patients to use and set up things around their home and to manage their breathlessness. And so they are very much towards patients and families. And what we also tried to do is that after people have been seen in the breathlessness support service, we wrote to them copying their family doctors. So we wrote and said, it was lovely to meet you, and we suggested that you do this, this, and this. We didn't write to their doctor and say, we met Mr. Jones and a lovely man, and we've advised him to do this. We wrote directly to the person because we wanted to put the control in the patient or the client and their family members, and often family members were involved in this, rather than put the control on the practitioner to do it. And I think that went down rather well, because people talked a lot about how there was a dignity to them, which when you're breathless, you often lose because you can't talk and you can't go to things, etc. And so part of the theory underpinning the intervention was to give people back some control in a disease when they don't have very much control.
Great, thank you. So Anna has a comment, which is a very important area. So she said, one kind of inequity that I'm particularly worried about is end-of-life patients with psychiatric diseases. What are your thoughts about it?
Well, we've certainly done a little bit of research on this, which we've published from the Cicely Saunders Institute. It's an important and neglected area. So there's two things. The first is that people with psychiatric diseases, like those from deprived areas, and there's an added impact of psychiatric diseases, although there's a lot of interplay between deprived areas and psychiatric disease, because people who have a psychiatric disease often struggle to get income and so on. Then in that interplay, there's an added challenge for people with psychiatric diseases. They often die younger than people who don't have psychiatric diseases. They often have poorer health, and they often have poorer engagement sometimes in some of the preventive things that might be helpful. So they often get sick. And because of that, they are very much in need of palliative care. And yet, we have a difficulty that they often don't have great palliative care experiences. And it is this difficult combination of psychiatric disease being one of the multimorbidities that people have, when they also have something else which is making them very sick, like heart failure or cancer or lung disease. And so it's that combination that you often end up seeing, which is very problematic. The other part of psychiatric disease, which I think is rather different but is important, is that people with dementias. And we know that that's a disease that's on the rise. It causes cognitive problems for people. It also causes other symptoms for people. It's often comorbid with other conditions and very much associated with aging. And we saw, and I showed you some dementia data, that people don't often get great access to palliative care.
Great. So just a comment, I see things coming up in the chat and also in the Q&A. It's easier for me if I can follow in the Q&A. So if you have something, maybe you can put it in the Q&A section. So there's a couple comments that I think are interesting to add. Kelly's comment about that is giving patient and family the autonomy that's really paramount. And Eric has a comment saying Dr. Higginson's mention of Hinton's perspective was and is still applicable. When the person dies, usually the voice dies with them. Interested in your thoughts about how to bridge the care between acute care and palliative care. We do well with high technology in some areas. We obliterate the misconceptions and place quality of life and living or dying in the forefront. A perspective from a frontline acute care ICU healthcare worker taking care of people on life support ventilators. How do we change the culture of the medical system and society? Breathlessness is an important overriding theme. If you cannot breathe, nothing else matters. So some important concepts. But I guess the main question in there is about getting the healthcare worker on board, I think, is some of the key things there. Changing culture.
Yeah, I think it's a wonderful point, and I agree with a lot in the statement. And I suppose the thing I'd bring it back to, which we tried to do, I think, reasonably successful in the breathlessness support service, and we've also tried to do with an intervention that a number of people have tried in intensive care, with a sort of slightly more holistic assessment that the staff will do of patients and of families to try and find out who the person is. Then I think that one of the key things is to work together in an integrated way. And it's not terribly always easy to do, because you don't, and it takes quite a lot of planning. We had to spend ages figuring out with the Breathlessness Support Service who was going to do what. We developed a similar integrated record, and we developed a shared assessment which was based around the iPods, which I have to say my respiratory colleagues loved, because they said, oh, this is great, we can find out what symptoms people get we don't normally know, you know, because they had been focusing on FEV1s and all the other things, oxygen concentrations. They're all valid, but they don't tell you how breathless somebody is. And they were interested in a walk test, which actually I learned quite a lot about as being quite important for people. So a 6-minute walk test, or a sit-stand test for those people who couldn't do it. But also they love the fact that they could do an IPOS with patients, and patients would do it before they came to be seen or before they were connected with, and then they could look at it and they could find out if people have got symptoms, and people could put on their key concerns. So sometimes somebody would write on their key concern, I want to write my will. And in a way, it gave clinicians an opportunity to open a conversation with somebody. So I think it's that integration, because a lot of people just in healthcare just don't have the language. I mean, you know, I'm frequently on call, and I have a call with a junior doctor who doesn't kind of know how to tell, because this is the first time they're doing it in the real world, that somebody has deteriorated and died. And, you know, we can teach them in a classroom, but when it comes to the crunch at 9 o'clock at night or midnight or whatever, and it's happened and they've got to say it, sometimes they're not so sure. And they're not so sure how to say to somebody or their family, look, actually, you know, we're doing everything that we can to treat the disease, but it's not really doing things. My message is actually, if they just pause and listen to what the patient says, they'll hear that, because quite often patients have figured it out and we just don't feel that we need to quite go in so much with the answer. So I do think it's about a kind of mutual respect and working together. But it's not always easy to do, because we're all very busy, pressurized, palliative care resources are thin on the ground, etc. So I hope that is some sort of answer, Eric, but it's a wonderful question. And I'd like to know your answer to your own question as well.
Well, I'm going to throw more questions at you before you throw them back. So there was a comment also about supportive versus palliative care, and I think you touched on it, how important it is that we explain those concepts. Naziruk says, a very interesting question around end-of-life values in different cultures and how to provide education and support to communities to seek help earlier.
So again, I do think that actually the patient and public involvement area here is very helpful and important. So the first of all is, have you got things in the language that people need? And in South London, we work with so many different languages. We have a table with about 50 different languages that are found in our different communities in South London. So although we have interpreters, we can't quite manage to have interpreters for them all. So we also have a telephone online service, which actually is rather brilliant. And you ring up and you get somebody, and then you have a little kind of phone, basically. And you sit there with the patient or the family, and this little voice comes out as you're explaining things in their language and your language. Because I speak a little bit of Italian. Those of you in Canada who speak both French and English will realize that actually you're probably very good at speaking 2 languages, but I'm not very good at not speaking my own language. And I certainly can't say anything very interesting in Italian. So I know that to explain something when I'm stressed and it's difficult and it matters to me in a different language is very hard. So I do think barriers like language, over and above cultural beliefs is very important. And we have all materials translated so that if people need the material in another language, it's available even if somebody has to read it to them or give it to them because they can't, because they have a literacy problem. And then I think there's an issue about working with those communities and trying to understand the perspectives and getting leadership within those communities about the sorts of things that might be helpful. So we have some fantastic, diverse communities of patient and public involvement advocates from the Cicely Saunders Institute, and they pitch up at various events. They've educated me a huge amount about things, and they are amazing advocates for those communities because they understand what people in those communities are saying. And I think that's more than education. I think that's about dialogue and understanding that sometimes what you're saying isn't quite what somebody's hearing. And it's that lost in translation cultural barrier that matters. And then there's all the things in the paper by Bajwa about some of the systems and assumptions that we make about communities, including about the role of the family and others, that actually we need to be careful about if we're respecting other communities. So I hope that's a step towards some kind of answer.
Oh, thank you very much. And I didn't get a chance to visit the chat group and emphasize so many people were saying how much they appreciated you and your presentation today. And we literally had coverage from Newfoundland in the east all the way to Vancouver in the west. So all of Canada was on board and hearing about you and what you're suggesting as we approach these equity issues. So in closing, I just want to say Professor Irene Higginson is recognized for her truly outstanding work in the hospice palliative care field, and for her and the Cicely Saunders Institute's continuing contributions to equity in hospice palliative care around the globe. We're so happy to have you today, and we apologize that we can't physically present you the certificate of recognition at this point. However, we have a screenshot of the award certificate as a token of our thanks. A framed version will be waiting for you at one of the next International Hospice Palliative Care conferences that we can attend. And we also sent an honorarium, which is just a token of our appreciation for this wonderful talk today. And on behalf of the organizing committee and our hosting organizations, we'd like to formally thank you, Professor Higginson, for your timely and provocative special lecture. And we also like to thank the audience for attending the 2021 edition of the World Hospice and Palliative Care Day special lecture, and wish everyone a great day and look forward to seeing you next year. All the best.